Hello everyone. Today we are going to see about history taking in central nervous system. But CNS per se, it is very easy actually. Everyone says in central nervous system it's very hard to take history taking. But in CNS only you have set of formats. For example, you have higher mental function, sensory, motor, cerebellum, meninges, and autonomic nervous system. You just have to understand in each and every section what are the things you have to ask. For example, you're taking a case of something. The most of the time, the case for you is stroke. We have cortical stroke, subcortical stroke, midbrain, and you have cerebellum and maybe spinal cord. We don't say in spinal cord there is stroke won't occur mostly, but the traumatic stroke can occur in spinal cord. But the most of the time, the common stroke they will keep you in the exam is subcortical stroke or cortical stroke. Midbrain and cerebellum they can ask you as a question, but the most common stroke they will put in the exam is subcortical stroke, that is the internal capsule. In the next video I will little bit give you an anatomy of what are the structures will be in the subcortex and what are the structures affected in the subcortical stroke, and cortical stroke, how to differentiate each lobe of the hemisphere, how it is you need to differentiate if this lobe is involving what are the structures it will cause defect. Okay, so next is for example, if a patient is coming of 63-year-old male coming with weakness, means first what are the things you have to ask. First you have to go with motor system. Okay, if you just take this case now, chief complaint of weakness in the right upper limb and lower limb, deviation of angle of mouth towards the left side. It's not 20 years, maybe this patient will come with half an hour or 2 hours before, because look, there are two terms, one is stroke, one is TAA. TAA means transient ischemic attack. It has to be resolved within 20 minutes. If a patient is coming to you, the patient is saying weakness and angle of deviation of mouth. So if the patient is having that symptom, it has to resolve within 20 minutes. If it is not resolving, it is causing more than 1 hour, it has to be a full-blown stroke. You have to treat according to that in stroke protocol. TA has a different treatment management, stroke has a different treatment management. First you have to how to write the HOPA, because the case it is very important in your practical exam. You have to start with the patient was apparently normal 2 days or 3 days back. He went back to bed normally, and the next day morning he found difficulty in using his right upper limb and lower limb. This is how the classical thrombotic stroke will present. Maybe hemorrhagic or embolic will be different, but the classical thrombotic stroke will be present like this. This is how we have to present the case. He had difficulty in raising his right upper limb once the head while trying to comb his head. This means that patient has a proximal muscle weakness and bathing. He also had difficulty in getting up from the squatting position. These are griddle muscle, pelvic griddle muscles are weak. After 3 hours, his weakened progress and the patient was not able to hold a cup of water with his right upper limb. This means the patient is having a distal muscle weakness. It is progressed from proximal to distal. This is how your full-blown stroke will evolve. This is how you have to present the case. Okay, wow. This is motor history. For example, if you take now here. Proximal muscles, difficulty in combing hair, reaching for high objects, winging, this is our proximal, that means your griddle muscle. Distal muscle, your wrist drop, finger drop, mostly it will be like buttoning, unbuttoning, holding a cup, writing some notes, this and all, distal muscle weakness. So you have to, the stroke will progress from proximal muscle to distal muscle. Okay, so you have to first say with motor history. If you say the motor history clear na, your crossed half of the history are done. Other thing are your higher mental function. You have to just ask whether there is an altered state of consciousness, because you have focal neurological deficit in space occupying lesion, because there will be like for example, you have neurocystic sarcosis or you have a brain tumor. These leads to altered mental sensorium with the focal neurological deficit. So then you have to say mental status and cognition, because some, if a dementia is patient having, they have altered cognition, but these higher mental function are not so important in a stroke patient. But for a hemorrhagic stroke, stroke, the patient will have a difference in altered consciousness, because hemorrhage will cause disrupt in the neuronal axis, so that leads to altered consciousness, cognition will be impaired. So these are in the acute stage, not in the chronic stage. So you have to understand these history, you have to ask, not in depth. They will ask you questions from this. Okay. Speech difficulty will be there. In stroke, speech is a separate topic. I will talk about speech in a different video. Difficult to recognize people or object, this and all small history, just you know to document has no history suggestive of higher mental function dysfunction. Then you have cranial nerve dysfunction. Cranial nerve dysfunction means if a patient is having a deviation of mouth, means it's indirectly significant the seventh nerve is getting involved in this. So it can be upper motor lesion of the seventh nerve palsy. So here other cranials are normal, seventh cranial nerve is most probably involved, other cranial nerves are, there is no dysfunction. So then we have motor history I have told. Then there is no, you need to like what to say, distribution of weakness is symmetrical, asymmetrical, and onset is how, progression you have to say. The thing I told you, then the HOP, this is how you have to present. This is exact scenario for each and every case. For example, hemorrhagic, thrombotic, embolic. Patient was what he was doing, how his weakness was started, how it is progressed, now what is the status, which are the upper limb or lower limb are involved, or your lower limb are involved, depend upon that you have to start the history. Then we have sensory deficit. Sensory deficit, you can say directly there is no involvement of sensory deficit, there is no history of cerebral history. Cerebral history means there will be tremor, bradykinesia, rigidity, this and all will be the abnormal nystagmus, this and all will be morely subjective. They won't ask you as, because these things will happen in cerebral stroke. So because you have to rule out whether the patient is having a cortical stroke or subcortical stroke, midbrain stroke, and have a cerebral stroke. If you say there is no symptom suggestive of cerebral dysfunction, if it is okay, na, then there is no issue suggestive of autonomic dysfunction like palpitation, postural hypotension, urgency, frequency, like ballad. But in frontal lobe stroke, you will do have abnormal involuntary passage of urinary incontinence will be there, but for it doesn't signify there is, you have autonomic dysfunction. It is higher mental function which controls your bladder, because your frontal lobe controls your urinary continence. Due to the stroke happens, the higher mental neurons will be lost, so that way you will develop incontinence. That doesn't mean the patient has autonomic dysfunction. If a patient is having autonomic dysfunction, they have a lot of symptoms like dryness of skin. The sympathetic system or parasympathetic system both will gone. Urinary retention, loss of conscious awareness of bladder control, this and all will be there. Then we have two things. One is headache and one is seizure. These two things are very important in hemorrhagic stroke, because the classical presentation of hemorrhagic stroke, patient is apparently normal 2 to 3 days back. After he develops headache, it will be for a subarachnoid hemorrhage, it will be a full blown headache. If it intracranial bleed, it will be not that much headache. Patient will have a mild headache. He will start developing vomiting, because there will be increased raised intracranial tension that will irritate your meninges. That meninges will cause vomiting. Okay, ma'am. Then we have seizures, because look, neuron is one structure which if you irritate, it will fire. So hypoxia can irritate, or bleeding, hemorrhage can irritate, anything can irritate. So patient can develop seizure. So hemorrhagic stroke, you can develop any three things: vomiting, headache, and seizure. So these three history are very important for your hemorrhagic stroke. Like we don't need to elaborate on seizure and all. For example, if the patient is having what to say, the seizure is associated with sensory deficit or motor deficit or a muscle spasm. This points actually for person clinical knowledge, for a case presentation, this much amount of detailed history don't need. Okay, ma'am. The patient has developed seizure, whether it is associated with the motor deficit and whether it is associated with anything. For example, any aura is there or any head trauma is there. Look, or 4 to 5 history. For example, if we see now here, in this you will say the onset duration and frequency, and there is motor deficit, sensory deficit as there or not, and aura is there or not, and head trauma is there, tongue biting. Okay, ma'am. This and all you will ask for the full blown seizure history. For your exam, there will be mostly no seizure history will be there. Mostly seizure history won't be there. So there is no need to worry for you guys, but do mention if it is a hemorrhagic stroke whether there is a seizure history there or not. Okay ma'am. Then we have headache history. Headache you can whether it is a throbbing headache or it is the severity, this and all you have to ask, but it's not very important to mention in a case history whether the patient is having headache. Just have to mention whether the patient is having no headache, no vomiting, no seizure. So next we go with past history. Past history you have to ask whether the patient is an asthma, COPD, TB, DM, hypertension, ischemic heart disease, any seizure disorder. This and all you have to ask, because like for asthmatic patient they will can develop arrhythmias. So the arrhythmias can cause stroke, because arrhythmia, if a patient is developing arrhythmia means they will produce clots in their vessels. So those thrombus can break into form embolic stroke. COPD is the same. TB can produce space occupying lesions in the CNS with neurological deficit, with like a space occupying lesion with raised intracranial, this can occur. And diabetes mellitus, hypertension, these can cause ischemic stroke. Then we have ischemic heart disease. The ischemic heart disease can the same thing. It can cause thrombus. It can break into emboli. Seizure disorder, like per se, they will ask you what are the things can cause seizure, because seizure disorder patient will have more prone for seizure, not to the stroke, because this is a neurological case, not a stroke case. So we have only stroke case. That's why I'm explaining you guys as a stroke. Okay, ma'am. So you have to focus on the stroke part. Other things are add on that. For example, seizure disorder asking now, sir, this is a neurological, so that's why I'm asking whether any seizure is, whether the family history of, for example, his father or mother, anyone has a stroke. And personal history, you have to ask. First one is smoking, alcohol. These two has to be asked for a stroke patient. If it is a female patient, there is no clinical significance between the menstrual history and obstetrical history. But if it is a post-menopausal female, they are more prone for thrombogenic stroke, because these people have a procoagulant state. So next we have general examination. The same conscious oriented febrile, but two things you have to mind in this: cooperativeness, obeying commands. Because some patients in neurological cases, they will have agitated, they have delirium, they won't obey the commands, they don't know, they will in acute delirial state, so they will be more prone to agitated state. So if you ask some question, they will be agitated, they will shout. Some patient will have a coma state, so you can't able to assess. So in the consciousness, you have to assess in Glasgow's coma scale how much the score, whether the patient is cooperative or obeying commands. Then we have pulse. One thing you have to understand is we'll have a Cushing reflex whenever the patient has a hemorrhagic stroke. Bradycardia, hypertension, bradypnea. This is Cushing's triad. We have another one, Cushing's reflex. That means it's depend upon whenever there is an intracranial bleed, there will be high BP. That means to compensate the bleeding, it will be high BP. This and all seen in your hemorrhagic stroke. Look, hemorrhagic stroke is most likely a emergency condition. The most common cause for hemorrhagic stroke in individual is mostly subarachnoid hemorrhage due to berry aneurysm. Other than that, intraparenchymal bleed is also there. We do have cases like intraparenchymal bleed, but depend upon that, they will ask you questions only. You cannot clinically find this is this area of hemorrhage, this is this area of hemorrhage. But you can say, from, for example, in a subarachnoid hemorrhage, there will thunderclap headache will be there, projectile vomiting will be there. This and all will be there in the hemorrhagic stroke part. And we have intracranial bleed. There will be less much of symptoms. There will be headache will be there, vomiting will be there, but the patient doesn't have any thunderclap headache, like severe headache in his life. Those things won't be there. You find hemorrhagic stroke from histories while he was doing some work. We have a separate I will have a separate video for like how to differentiate thrombotic and embolic and hemorrhagic. Okay, then we have to see about the blood pressure. I have already told pulse, blood pressure, respiratory rate. These three things you have to remember in Cushing's triad, how it is going to be. Carotid and vertebral buoy. This is very important in a stroke case, because if a patient is having carotid buoy, you have to examine the general examination. You have to place the stethoscope in the carotid. Okay, ma'am. Then you have to look for any bruise. Vertebral artery you have to place in the posterior neck, the above the shoulder, posterior neck. Okay, ma'am. There you can hurt any bruise because the vertebral artery is and your carotid artery are the two things that are supplying your brainstem and entire your brain. So if you have any bruise here, that means there is something is blocking. That means there is a athyroma is there. So that athyroma can block totally the carotid, because if you see in carotid artery strokes, those strokes are mostly embolic because there is a plaque will be there. The plaque will form thrombus. The thrombus will break into form a embolus, or the entire thing carotid can be blocked. So you have to understand carotid and vertebral bruit can cause stroke. Those are because the athyroma, not due to thrombus will form in your carotid. Carotid artery is first your coronary arteries can develop the athyroma, and your abdominal aorta and your popliteal and your carotid. So this and all can cause stroke in your. In history you have to understand these are the points you have to know. The higher mental function and all, you just need to understand what are the points you are going to ask. Altered state of consciousness, mental system cognition, or some other history like speech difficulty you have to mention. Then cranial nerve dysfunction, motor dysfunction, how you are going to proximal, distal, this is how it progressed, and sensory dysfunction. Anything is there you can mention, but mostly for a stroke patient there won't be any sensory dysfunction will be noted. And cerebral dysfunction, there is no much of a thing will be there because cerebrum will be intact in cortical and subcortical stroke. For UG level, these two cerebral strokes are PG level. And autonomic dysfunction, then we have some common headache and seizure. If you have a seizure, full blown seizure, it will be come under seizure disorder. It can be associated with hemorrhagic stroke. You have to know if the seizure is associated, you have to know the onset, duration, frequency, how many episodes, whether it associated with this sensory and motor deficit or not. This is how you have to take a history in CNS. Okay, thank you.